Hello, good evening, everyone. You'll have to excuse me. I'm going to put my glasses on and off all night, so sorry about that. Welcome to the Young Onset Dementia event tonight, which is run with Capital Health Network, as well as the Health Pathways program in the ACT in Southern New South Wales. And obviously we have speakers from CHS and the University of Canberra as well. My name's Jill O'Donnell, and I'll be introducing the speakers tonight. First of all, I'd just like to acknowledge the Ngunnawal people as the traditional custodians of the lands that we're meeting on tonight, and pay my respect to elders past, present and emerging. And I also extend that respect to any First Nations people who are attending tonight. I'll start off with the housework. You've probably found the fact that we have coffee and drinks, and the ladies' toilets are out that door in the corner, and down the hallway at the top of the stairs, you'll find the men's toilets. There's an emergency exit, which is back down the stairs you came up, as well as a couple of signs that take you down the hallway. And tonight we have a range of staff here. First of all, the staff from Capital Health Network. We're the ACT's primary health network. For those of you who don't know, there's 31 PHNs, primary health networks around Australia, and we're the ACT one, which is the best of them. And tonight we've got Kate Eigner's our quality improvement manager in the primary care team, and Canal's our events lead, who does all the organising of these events, along with Leonie, who's here as well. Myself, and I'm the Health Pathways manager for ACT in Southern New South Wales. And Mel, who I can't find, she's still downstairs. She's also here from the Health Pathways team. If you'd like any help, just speak to any of our staff here across the evening, or any advice about anything you might see or hear, just get into and come and have a chat. And also, obviously, Ramada staff are here to help with all the catering, etc., and logistics. As you can see, we'll be starting on our first speaker in a minute or two. There's obviously canapes have come around partway through the speakers. There will be more food that comes around, and then we'll have our 3 speakers across the evening, 4 speakers across the evening, and then we'll have a little bits of discussion potentially, or Q&A in between, but we'll have plenty of time at the end to do Q&A and have some discussions. And I'm sure it's such an interesting topic. I'm sure there'll be lots of discussions at the end as well. And we'll be having time at the end to have some dessert as well as discussion before we finish up. So tonight we have the 4 speakers, as I said, 4 presentations. First of all, we'll be hearing from Jennifer Lobb, who lives with dementia and having been diagnosed at a young age. Jennifer is now a Dementia Australia advocate, and she'll be our first speaker in a few minutes. Following on from this, we have 3 Canberra-based experts in the field of young onset dementia. Philip Fletcher, who's a cognitive neurologist. Zoe Alcorn, I'll introduce everyone separately on the way through, who's a clinical neuropsychology registrar, and Nathan Dacuna, who's an associate professor at the Centre for Ageing at the University of Canberra. So, as most of you will probably be aware, there's among the people diagnosed with dementia, there's approximately 29,000 people living in Australia with young onset dementia, which means the person was diagnosed before the age of 65. It's not a separate condition, it's just the fact that it has been diagnosed at a younger age. So our speakers tonight will be discussing the recognition of signs and symptoms that may indicate a person has early onset dementia emerging, and features that separate these patients from the so-called worried well. So we'll look at some screening tests which are appropriate for use in primary care, and go on to look at the diagnosis and ongoing care. And there's some really interesting talks coming up tonight, which I'm really looking forward to. So part of my job as the Health Pathways Manager in ACT and Southern New South Wales is the fact that we have to plug Health Pathways. It's a platform that, if you're not aware, has it's an online platform that's got evidence-based, localized information, clinical referral information that's available to all health practitioners in ACT and New South Wales. And we've got some cards and things down there you're welcome to go on to if you want to get a personalized login. There's about 50 plus health pathways programs worldwide in Australia, New Zealand and Canada and the UK, etc. in the ACT Southern, we have more than 670 localized pathways, and there's 3 types of pathways: there's clinical, referral, and resources pathways. Excuse me. So health pathways provides clinician support and system integration. So essentially, it gives advice on assessment, management, and where to refer patients to, when to refer and where to, as well as resources for clinicians and handouts for patients, that sort of thing. There are mapped services. So across the region, we have information on there about all the local services that are available and the service-specific criteria for those, because as you know, there's a big move now to across to e-referral, and service criteria are really important for non-refusal of referrals, so that the patients get directly to where you want them to go to without being bounced back. There's just a few of the pathways that health pathways we have. You can see there's a really vast area. There's a really vast reach of types of pathways. It's not all clinical direct to a specialist. There's a whole range of wraparound services and all sorts of things that are in there as well, just to let you have an idea. Health pathways, as I said, you can have a health pathways personalized login. That gives you access to smart search, which is an improved AI assisted smart search function. You can also, you can see on the right there, you can actually generate CPD points and record your CPD points and CPD records there by searching up and doing some research. This event is partly funded by the National PHN, National Health Pathways Dementia Program. And so part of that, we also produced some resources which are patient-facing and carer-facing for people living with dementia and their support people. So those are available. We've got links to those there as well. So now it's time to introduce our first speaker. So Jennifer Lobb, as I said, is presenting us tonight as a person who has lived experience of having been diagnosed with dementia at a young age. And Jennifer now works as an advocate with Dementia Australia. Welcome, Jennifer.
I'll have to stand there, yeah?
Yeah.
Okay.
Just watch that.
Is this, yeah?
Just watch that. Yeah.
Are we ready? Yeah, I'm not very good at standing still, so we'll see how it goes. I think I'm here, as you said, to talk about my journey to getting a diagnosis, not what it's like living with early onset dementia. So I was sort of diagnosed when I'm 63 in a couple of months, and I was about 61 when I got diagnosed, like when somebody said, oh, that maybe dementia had come up. But before that, there was a bit of a journey. Of course, I retired from my job as a teacher early because, well, I was getting angry. That's why I retired. I was ticked off a lot and I got angry, but now I look back and that could have been a symptom. But anyway, eventually I went to the doctor though, because over the years I'd had problems with speech, some body tics, and things like that, and I had problems sometimes swallowing and choking. So I went to a doctor about that just because I had time. I wasn't particularly concerned. They were things I lived with. The first doctor I went to was my local GP, who was really nice. And I explained my physical things, but I really didn't talk about the mental problems I'd had, like now in hindsight, not remembering things, forgetting, the anger, I lost compassion for people that I loved, things like that. So he was really nice, and he didn't do that, that test that everybody gets at the beginning. He didn't do that one. So, but he said I should see a neurologist. I tried to see one in Canberra, which, if you're obviously from Canberra, to get on a queue for something can take forever. So I got on a queue to see a couple of neurologists here, but I was at least 6 to 8 month wait, maybe a year. So I went up to Sydney and I saw a doctor up there, I think his name was Dr. Roland Freitas. So he was somewhere in North Sydney, and he said he didn't do the memory test either, and he thought I had either Eglon 5 or motor neuron disease. So that's what we went home with after that, which was scary. And then, so I just continued to see him. He didn't do much. He put me on some pills that were supposed to help with the shakes. I can't remember. Simipex? No, I can't remember. Anyway, some pills for that. And he treated me with that. So I went up and saw him up every now and again, or when he came here. I think he had an office here. During that time, I never got any better. My brain got foggier. The world became a bit grey. And then I got a call from the office of Dr. Jai here, and that he's a local and he could see me. So we thought, well, it would be nice to see a local person. So I went to see him. He did the test, the brainy test, and he then went, not sure about that because nobody had done it before. So with him over this time, and I can't remember when, I had a CT scan, a PET scan, the MRI. It had 3 lumbar punctures, not fun. One of them, and then he sent the stuff from my spine down to the Laurie Institute or somewhere in Melbourne. Laurie? I don't know, you guys will know. So it went to them, and by then he'd sort of said, yeah, you've got dementia. So we'd sort of start looking at, the dementia advocacy groups and things like that. But we still, weren't really sure, because I was still ticking and bluddering and all that, sort of choking. But when I went to see him over that time, he said, results came back, you've got AD, Alzheimer's dementia, which was fine. No, it's not fine, but we thought that's okay. But then, and I moved on and we lived with it and we planned our life and we did all, it was fine. I'm not sick, so I can't complain. I'm a bit crazy, but I'm not unwell. So I've got really nothing to complain about. And then someone from Dementia Australia recommended I see a geriatrician, even though I'm not old enough. They said, go and see one because I had dementia. I went and saw a lovely lady here in Canberra. I mean, I wish I hadn't seen her, but she was really nice, So she didn't think I had dementia either. She thought I had myoclonus dystonia. I don't even know what that is. But she thought I had that. So she sent me to Dr. Lewis at the Woolcock Institute at Macquarie Hospital, or Macquarie Searchy thing. He said, no, you don't have dementia. He said, no, you have Eglon 5. So, and I knew what Eglon 5 was by then because of, Googled. And he said it was Eglon 5 and everybody else was doing the wrong thing. And like he had all my stuff, so anyway, so then he sent me to Professor Mahant, who was a movement specialist at Westmead Hospital in Sydney. Took me months and months to get on, these appointments took over 2.5 years altogether. And he said, there's nothing wrong with me. Nothing wrong with you, you're fine. He said it was all in my head, not there. So that sort of left us we just didn't know what to do then. So I had an appointment upcoming with Dr. Jai again, and so this is the worst thing that happened to me. I mean, all these things were crazy, but there was one lady who, I'm not going to say any names. Anyway, I I have a lovely local GP. She's a lovely woman, really kind, friendly. And I just needed an extra referral to go to back to Dr. Zhai, you know, they run out. So she was away, so I went to my local GP clinic and I saw another lady there. I just wanted a referral, 5 minutes, in and out. So this lady proceeded to take my whole history. When did my parents die? Why did they die? And you know what? I lied. If you ask me when my parents died, I can't tell you because I don't know. What did they die of? I think my father killed himself. My mum had cancer. What sort? I don't know. So she asked me all those questions. I just lie now. If you ask me them, I'm just going to lie to you because I can't remember. And, you know, so she asked me all those questions and she decided, I'll tell you this, that's what that lovely doctor said. She said that I'm just a very gentle person and I must really like puppies. And that there was nothing wrong with me. I had seen in a 10-minute interview just to get a script. That was the last there. So by the time we got back to Dr. Zhai, I was a mess. My husband was angry. All the symptoms that I'd had were still there. Nobody was doing anything about it because whatever. And he was fabulous. Oh, am I allowed to say Dr. Zhai's name? It's too late now. Anyway, so he was very kind. He took the time to show us everything, the reports from X, Y, and Z, and that said, this woman has Alzheimer's dementia. And so that's what I have. And that's how I got there. And it took me two and a half years to feel confident that that's what I have. I mean, I've had it off and on, I guess, over the 2.5 years, depending on which doctor I spoke to. But I feel confident that I've got Alzheimer's dementia. And yeah, so that's how it happened. I did write down one thing, because I probably only spoke for 5 minutes now, haven't I? I've waffled too quickly. Sorry. That I have joined the Dementia Australia and I just, met lots of really nice people along the way and other people like me living with dementia, especially younger onset dementia. And I mean, I know it's just hearsay, whatever. A lot of the women that I spoke to who went in thinking they had dementia often got diagnosed with problems relating to menopause. I've never heard of a man, obviously, or a man in our group say, oh, he didn't believe me or he thought it was something else. Only the women say that they think they were often just told that, have you been through menopause, love? I didn't have that because I didn't take that road. I didn't start with dementia. I started with motor neuron disease. But when it got to those women, they were, okay, if I go, I'm just getting old. And that's I think something that needs to be thought about if you're a doctor. So I think that's it, unless I don't think anybody has questions. Do you have a question? Does anybody have questions? No? Oh, there's a lady there. Okay.
So it's been very helpful. That sounds like a terrible journey, and thank you for sharing. But what's been helpful?
Okay, so I'm going to say a lot of stuff very quickly. So please interrupt me if you want to ask questions as we're going along, but I'm mindful of time.
As in, yeah.
Yeah. Okay, so I am in the process of setting up a specialist cognitive disorders clinic run by neurology in conjunction with Zoe, who's a neuropsychologist. And the reason we're doing this is that we want to, we'll see any patients who are presenting diagnostic challenges, but we want to focus it on people with younger dementias where they're often rarer and more unusual presentations, and therefore there's often a delay in diagnosing them. And as Jennifer mentioned, there's this arbitrary cutoff at 65 for NDIS, and you see people who are missing it because of length of time to get a diagnosis. There's also issues now with new disease-modifying treatments for Alzheimer's disease, which is not the focus of my talk today, but I'm happy to do a talk about that at some point if interesting. The point with those is they're expensive, they're dangerous, and they're probably most effective used early. So you have to be using them in the right patients. So it's imperative we identify people with Alzheimer's disease and other dementias early. So just to remind ourselves, when we talk about dementia, it's not a disease, it's a syndrome with multiple causes. Usually in this context, we're talking about neurodegenerative processes where you develop abnormal protein deposition in the brain, which damages nerves. Some dementia is genetic, as in underpinned by a single gene, normally autosomal dominant, but the majority is not, and then we call it sporadic. And in sporadic dementia, there's some interplay of your genetic predisposition, your genetic constitution, plus environmental factors, which together set off this cascade of misfolding proteins for reasons we do not understand. And we do not understand why in one person it will be a particular protein, and in another person it will be a different protein, and in one person it will affect one part of the brain, and in another person it will start in a different place. Either way, these proteins damage nerves, and then they can also propagate, like CJD does, the proteins propagate through neurons, and therefore through neuronal networks, and you get spreading symptoms. And you also get particular patterns with different types of different individual proteins, depending which networks are more affected. So just to illustrate this point here, this is a coronal T1 MRI brain scan of a patient with semantic dementia. On the left, if I move this cursor, can you see that? No, okay. On the left, you'll note there's anterior temporal lobe atrophy. Yeah, we call that knife edge atrophy, but you'll also note there's atrophy on the right side, which is here, to a lesser extent. And the thought here is that you start off with a stochastic insult in one place, it spreads locally through interneurons, but then with time it will travel through long-range neurons into the alternative network, and you'll develop symptoms in parallel. So again, this patient, for example, might present with language problems, semantic problems, but they will also start to develop something called prosopagnosia, which is the other anterior temporal lobe where you can't recognize faces. And this picture here, I think, is quite nice just to illustrate this. This is cortical thickness mapping. So you can see the brunt of the pathology in yellow over the left anterior temporal lobe, but with time it spreads backwards and forwards. So this patient will be developing more language problems and behavioural problems when it goes into the frontal lobe. But if you look, you can also see it's spreading in the right anterior temporal lobe as well. So when we talk about young onset dementia, Alzheimer's is still the most common cause. However, it represents a smaller proportion than in older people, and other dementias become more important, in particular frontotemporal dementia. With FTD, it's an erosion of personality. It's devastating for family members, and it's affecting young people, often with young children who are still working. So I thought I would just focus on these two for tonight, just talk about how we might go about approaching a patient in clinic who we think might have either of these. So if we start with Alzheimer's disease is underpinned by amyloid and tau pathology. In most people, it affects the mesial temporal lobes predominantly early, and that's a parahippocampi and hippocampi gyri, so people present with episodic memory problems. Patients normally use the term short-term memory and say my short-term's affected, my long-term's okay. We call this one the amnestic variant, it's the most common. However, there are also rarer presentations of Alzheimer's disease, which we call the posterior variants. In these cases, the pathology begins in the posterior parietal lobes for some reason rather than the mesial temporal lobes. If it starts in the non-dominant hemisphere, people develop visuospatial dysfunction early in a condition called posterior cortical atrophy, and they may come to you saying they can't read properly, they're having difficulty driving. Anecdotally, I've had a few people where they've come having seen several optometrists or ophthalmologists because there's a problem with their eyes, and they keep getting new glasses and their eyes don't get any better. And it's not a problem with the eye, it's a problem with the visual processing. The other, I was going to say, does anyone know who this is? Thank God. Who is it? It is Terry Pratchett. I wasn't sure if this would translate across the world as well, but this is a Scottish author who used to write fantasy novels. And because he was a writer, he noticed problems very early. He had PCA, and he was looking at his laptop and the words weren't quite working, they weren't making sense, they were overlapping, and he had a very focal problem at that point, and you can see how easy it'd be to misdiagnose that at that stage. If the dominant hemisphere is affected first, people develop language problems, a type of aphasia called logopenic aphasia, where they have progressive difficulty with word finding, they develop hesitant speech, they make speech sound errors. It's felt to predominantly be a problem with verbal working memory. I'll talk more about LPA when I come to aphasia in a minute. So these posterior variants are not as common as the amnestic variant, but you'll notice in younger people, they represent a much larger proportion. And just to reiterate that point again, they're often presenting with unusual symptoms. So it's very easy for them to be misdiagnosed at the start. So how do we go about assessing patients? I'm sure we all do this. You obviously start by watching the patient and seeing how they walk in the room and how they interact with you. Useful signs, I think, include the head turning sign, which is not diagnostic of Alzheimer's disease, but it's very suggestive. It's when you have the patient sitting there through the consultation, when you're asking them a question, you notice they're turning to the person with them for reassurance. And I think it's a behavioural pattern that sets up over time as they lose confidence in their answers because they're feeling shaky about their memory. You'll be listening to their speech. Are they making sound errors? Is a prosody? Is the flow of the language normal? An interesting one as well is if you watch how they sit down, sometimes people just seem to fumble slightly for the chair as they're sitting down, which can be indicative of visual spatial dysfunction. Doesn't happen that often, but when you see it, you're like, oh, I think I know where this is going to go before the patient's even said anything. And similarly, when you're putting on your coat, sometimes people fumble getting an arm into a sleeve, which can be dressing apraxia. That's also a non-dominant parietal lobe problem. You'll observe how they appear. Are they well kempt? Do they have good interaction? Do they seem depressed? Do they seem appropriate in their behavior? Do they seem garrulous? Do they seem withdrawn? Do they seem a bit impulsive in their responses? For example, when they get out of the chair at the end. I normally do an MMSC, not because it's particularly useful for picking up early dementias, but it's always a standard way of checking a patient's progress when you're seeing them for serial follow-up. And then I normally go into a little bit more bedside testing. So I use a book, which has a few cognitive tests in it. Excuse me. This is a picture of 10 objects. You ask the patient to name them. You can listen to their speech, see if they have any anomia. You can also watch how they're holding the page, because patients developing visual spatial dysfunction might hold the page in a different angle so they can't quite see it. And then you tell them afterwards, in a few minutes, you're going to ask them what the objects were, and that's delayed recall. It's better than 3 words in the MMSC. For visual spatial function, you can get people to copy intersecting pentagons, which is on the MMSC. If you're feeling slightly more adventurous, you can do a 3D cube, which is slightly harder. And a common bedside test is to ask a patient to draw a clock face and see how they approach it. With this one here, you'll notice they put all the numbers on one side, so they probably have a neglect, hemi-neglect, visual neglect. You can do a few further things: fragmented letters, fragmented shapes, and 3D block design. I like the 3D block design. In the top one, they can see all 5 blocks. In the middle one, you can see all 7 blocks, but 2 are partially obscurated. And in the bottom one, you can't see one of the blocks. So you have to hold the image in your head in 3D to know how many blocks would make it up. You like this kind of thing if you do neuropsychology. It's interesting. I'm getting some glazed looks, I think. To test dominant parietal lobe, the simplest thing to do is test mental arithmetic, and you can check for logopenic speech again. Any questions about Alzheimer's at that stage before I whiz on to FTD? Because I've only got 20 minutes. Right, next. So frontotemporal dementia, group of disorders, frontal temporal lobes. Most common form is behavioural variant, where the brunt of the pathology lies in the frontal lobes. If the orbitofrontal cortex is more affected, patients can develop changes in personality. They can have problems with regulation. They may become disinhibited, inappropriate, garrulous, lose social cognition, not read social cues anymore. They may go the other way and become emotionally blunted with a lack of emotional response, or they may appear very apathetic, which can be mistaken for depression. If the dorsal prefrontal cortex is affected, they have problems with sequencing and set shifting, known as executive function. Excuse me. There's then also primary progressive aphasia, where patients present with language problems. This falls under FTD, even though LPA is an aphasia as well, because it's a language-led syndrome. The first one's semantic dementia, where the main pathology is on the anterior temporal lobe. If it's the dominant temporal lobe, people develop language comprehension difficulties, semantic deficits. If it's the non-dominant temporal lobe, it's more face recognition. The other one is more problem with motor output of speech, is a bit further back, focused around the insular cortex and perisylvian fissure. Patients have difficulty articulating sound and coordinating the various movements involved, so they have motor speech orofacial apraxia. They also develop agrammatism. And then just to reiterate again, that logopenic aphasia comes under primary progressive aphasia, but we tend to treat it separately because it's underpinned by Alzheimer pathology and has other Alzheimer features with it and progresses as Alzheimer's. So to test frontal lobes, a simple test is a LORIA test. It's a 3-step sequence. The patient has to copy it, which they can find difficult. And on the right, this clinician's checking for frontal release signs. So your frontal lobes inhibit primitive reflexes. And when they're damaged, you get re-emergence of these reflexes. Here he's testing for a grasp reflex, where you stroke the patient's hand and they will involuntarily grasp it. The other one I find useful is a Stroop test. In this test, you ask the patient to read the words going across and down, blue, green, red, and then you ask them to tell you the color of the ink, but not the word written. So red, blue, green, I find that difficult, which I do think that is significant. I learned to blur my eyes to do that. Your natural prepotent response is for language. So you have to be able to inhibit that automated response and override it, which is challenging for people with FTD and for me, it seems. Right. For semantic comprehension, you listen to the speech. The flow of the speech will be normal, but it will seem empty and devoid of content as they lose word meaning. They often talk around the word they can't think of or the object when they don't know what it is, and that's called circumlocution. This is called a cookie scene jar, cookie theft scene jar theft, cookie, some combination of those words. And it's quite a standard one used. So if you listen to this patient with semantic dementia,
can you see? Oh, they got stuff in that.
I might just turn that down slightly before we all get deafened. Where's the volume? Is that the, oh, I can do it on here, look. Okay, sorry, so doing that again.
Is their mum, and she's doing the stuff round. Okay, it's nice, isn't it? Well, what can you see here? Oh, this one. This one is the
So if you were looking at that picture, you wouldn't know what that patient was describing. So her speech sounds normal, but it's empty. She's going, oh, this one, the thingy there. Oh, the mum's doing a thing with the thingy, because she doesn't know the words and she doesn't know what these things are anymore. You can also ask patients to identify things, because if you ask them to name it and they have anomia, which isn't specific to semantic dementia, they won't be able to do it. But if you say, for example, what is the name of a seat without a back? You know, you should be able to do that. What is a hard outer case that covers animals such as tortoises and snails? Very good. None of you have semantic dementia. Or you can go back to the same pitch and say, point to the one that you would hang clothes out with, point to the one that is a musical instrument, so on. And what's really interesting is semantic dementia, although it presents with language, it's actually a global decay of semantic knowledge. So people develop loss of knowledge of other things as well, smells, sounds, objects. So here this patient is being asked to draw, excuse me, a rhino and a peacock over a period of time. And you can see that he knows they're both animals, but a peacock, for example, is taken on a very generic 4-legged animal shape because he knows it's an animal. He can no longer remember it's a bird, but he still remembers it has a tail because that's the most salient feature of a peacock. And a way to test for object semantics is to give them some keys or something and clinically say, what are these? What do you do with them? I had one patient who's a High Court judge back in London who, when I gave him a screwdriver, he was poking it like that because he could recognize that as a tool, but no longer recognize that as a screwdriver. And then just remind ourselves again, the right anterior temporal lobe is prosopagnosia, which is face recognition. So you do a similar semantic thing. You say, which one is involved in politics? There's some response inhibition involved in my part there. And which one is involved with the monarchy and so on. Okay, so progressive non-fluent aphasia. Here it's motor apraxia, so there are speech sound errors. If you get patients to repeat words like porcupine, hippopotamus, they'll mix up the phonemes and they become agrammatic. So listen to this lady's speech and see what you think.
activities or like to get something.
So I'm stopping there, yeah, because there was speech sound errors, yes, but there was also some agrammatism because she said to give him to its sister. That's why I stopped at that point, so it was fresh in your mind. And you have written agrammatism as well, so don't push to me, early my wife to go to work. And then the other thing, they develop other facial apraxia, so they can't coordinate the sounds, but they can't coordinate other facial movements. So if you ask them to demonstrate how you blow up a candle or blow up a balloon or give you a cough, they can't do it. And I anecdotally find asking people to give you a cough is the most sensitive. They literally go, cough. They do the inhalation and then it's like, cough, because they can't voluntarily do that. They can spontaneously cough if needed, but they can't voluntarily do it. It's a very interesting disease if you're interested in those things. And then finally, just to listen to the speech of logopenic aphasia, remember I said there's often word finding difficulty, anomia and pauses. This is a subtler one, I think.
What's going on?
Okay, there's a young girl and she wants some cookies and her brother is on
Do you
a
just hear this?
stand going up to get cookies for her. And mum's over here, she's washing up and she's got water on the
It's subtler, isn't it, this example, but there's some hesitancy. Then the other thing, oh, the other thing as well, it's not on this one. The main thing with logopenic aphasia, I don't have the slide here actually, it's dropped off, is that because it's working memory for language, they have a massive length dependent effect. So the longer the sentence, the harder it is to retain it online. And I just have an example I can play at the end if we have time of Zoe doing it as well, where she's repeating sentences. And it's like, it is sunny today. It is sunny in Canberra today. In Canberra, it is sunny today and tomorrow it will probably rain. And as it gets longer, people can't hold it online anymore and the words will start to get mixed up and they remember the gist of what they're trying to say, but it breaks down. When you do it, you use quite semantically meaningful sentences and you repeat the same sentence, which actually reiterates that I'm meaner than you. I go for semantically bizarre sounding sentences because it's even harder to hold it in your head because you can't rely on the semantic knowledge cues. Oh, no, I've got it, sorry.
The sun is shining in Canberra today.
the sign is
She's mixed up the phonemes for sun and shine there. She said sign rather than sunshine.
shining in Canberra today.
Good. Excellent. Brilliant. And another one. The sun is shining in Canberra today, but tomorrow it will rain.
The sun is shining today in Canberra. But tomorrow.
Yeah, gets harder. Can't hold it online. Gets members the gist of the sentence, but can't hold it. And that is the most useful thing for logopenic aphasia because you can see how the speech errors can sound quite similar to PNFA. The reason I'm really reiterating this point is that logopenic aphasia is normally underpinned by Alzheimer's pathology and PNFA is by tau. So if disease-modifying treatments do come into clinical practice, one of them you potentially be treating with these high-risk, high-cost drugs, and one of them subtly inappropriate. So it's important we get better at diagnosing accurately and early. Okay, thank you. It probably took longer than it should have done, so I'm guessing no time for questions.
Does anyone have questions for Philip at the moment?
Right. Yeah.
Do you find the neurotypicals and neurodivergence that there's a difference in the presentation of symptoms?
I don't know.
Okay, cool. That's the answer I was expecting.
Like I don't know. They're too rare.
Yeah.
They have a data set to be able to like compare the two. Yeah, yeah. there's a lot of undiagnosed autism, I think, in men, for example, where it comes out later in life and you wonder if it's FTD or not behavioural development. But I don't really answer that question.
Do you know something about dementia in people with Down syndrome?
Yes. What do you want?
Well, just I've had a couple of patients with Down syndrome.
So Down syndrome. Okay, so Down syndrome is 5721. The OCP, amyloid precursor protein, is on chromosome 21. Hence why they invariably develop Alzheimer's. Yeah, it's Alzheimer's. It's Alzheimer's. There are 3 deterministic genes for Alzheimer's. Autosomal dominant currently, APP, presenilin 1 and presenilin 2. APP gene is on chromosome 21. Yeah, it's inevitable, unfortunately, they'll develop Alzheimer's disease.
Years ago, I had some people coming in asking for ApoE testing. I'm past now.
Oh, your Pandora's box. Okay. So ApoE is the main risk factor, isn't it? The risk gene we know of for Alzheimer's. And if you have ApoE 2, 3, and 4, so there are 6 combinations. If you are homozygous for ApoE4, you have a 15 times higher risk compared to sporadic baseline, not compared to genetic, of developing Alzheimer's, yeah? But it's still not routinely tested in clinical practice because it doesn't mean you're going to develop Alzheimer's disease and what you're going to do with that information. Like, irrespective of your ApoE status, if you develop symptoms of Alzheimer's disease, you're going to get worked up and tested, and if you've got it, you're going to be treated accordingly on. So it's my understanding is it's not used in routine practice, but if you privately, I'm sure people can get all sorts of stuff.
Thank you again, Philip. That was fascinating. Our next speaker tonight, Zoe Alcorn, is a clinical neuropsychology registrar based in the Rehab and Aged Care Services Division at University of Canberra Hospital. She has a strong clinical and research interest in early identification of neurodegenerative conditions in younger adults. Welcome, Zoe. Shall I kick that onto you, Audrey? Oh, sorry.
Thank you. All right. So good evening, everyone. My name is Zoe, and I'm a neuropsychology registrar with Canberra Health Services. And as part of my role, I follow up patients who have been referred by Dr. Fletcher, who are seen in his cognitive disorders clinic. But I also see patients referred by the geriatricians through the memory assessment service at the University of Canberra Hospital. As we know, neurodegenerative diseases such as Alzheimer's disease and frontotemporal dementia can go undiagnosed for many years. And we heard this from Jennifer before. And distinguishing them from normal aging as well as psychiatric conditions can be challenging. And this is particularly true for young onset dementia, which can often present with atypical symptoms, which can be frequently misattributed to things like stress, low mood, anxiety, or other non-neurological causes. Detecting young onset dementia accurately and in a timely way is critical for many reasons, and Dr. Fletcher mentioned some of these before. Some of these reasons include allowing patients access to appropriate supports and services, enabling them to plan for the future. Many of the patients we see remain in the workforce at the time of their diagnosis. And early diagnosis also allows for consideration of disease-modifying therapies as these become available. So today I'll discuss the types of cognitive complaints that may serve as red flags for an underlying neurodegenerative process. in contrast to those which may be more suggestive of worried well presentations. I'll then outline the role of neuropsychology in the assessment of young onset dementia. And finally, I'll highlight a few brief bedside tools in addition to those discussed by Dr. Fletcher, which can offer valuable diagnostic insights and can be used by a range of clinicians. All right, so before I move on to discussing those things, I've got two examples of cognitive complaints here, and I'll read through them both, and then I'd like to ask you, which patient are you more concerned might be presenting with a neurodegenerative condition? So the first patient is a 63-year-old woman I saw in clinic. She says, the wheels have fallen off. I've gone from being at the top of my master's cohort to operating like someone with a learning disorder in a matter of months. I cannot put a sentence together or cope with a professional conversation. I used to have a brilliant memory and now I can't remember anything. I lose track of conversations, or I forget conversations almost immediately after I've had them, and I lose track of what I'm saying mid-sentence. So that's the first complaint. This is from another patient, 64-year-old man. He says, my memory probably isn't as good as it used to be, but I think it's probably just getting older. I've always been a bit forgetful anyway. I've never had a great memory for names or little things like that. My wife tends to notice it more than I do. So maybe let's do a show of hands. Who's more concerned about this first patient? Yep. Few people. All right, what about this second patient? We've got few down the front here. All right, so let's have a look. So this first patient had lupus, and she had entirely normal cognitive function compared to other women her age. And in fact, memory was sitting at above the 98th percentile. She had co-occurring depression. This second patient had early stage Alzheimer's dementia. So I'll draw your attention to a few things that stand out about this first complaint. So the history is very short, so a matter of months, which wouldn't be typical for a neurodegenerative disease. So we don't tend to see patients in the very earliest stage of developing dementia. They've usually noticed symptoms for about 6, minimum maybe 12, 18 months, either them or a family member. It's a very emotionally charged complaint. So the patient's drawing your attention to her cognitive difficulties very obviously and prominently. The complaint also incorporates a lot of different cognitive symptoms in just that very brief sample of her complaint there. So mentioning difficulties with memory, with language, with attention, again, which have evolved over a very short span of time. If we look at the second complaint, this is a classic example of what we call a muted complaint. So the patient has a sense that his memory's worsened, but he's also quite dismissive of the problem. So attributing it to probably getting older, probably having always had some difficulty with memory. He also acknowledges that someone else is a bit more concerned than he is. So let's elaborate on this a little bit more. So as I've alluded to, when we're talking to the patient and usually a companion, certain subjective and presenting features are very important in helping us differentiate between patients who are developing a dementia versus those who are what we call worried well. And sometimes these are counterintuitive. So firstly, as Dr. Fletcher mentioned, we consider, did the patient attend the clinic alone or did someone else come with them? So kind of from anecdotally, but also there's a bit of evidence around this to say the patients with Alzheimer's and other form of dementias tend to present with someone else, so someone else who is concerned about them. Do they turn to their partner when you're asking them questions? So what will happen, Dr. Fletcher mentioned, you ask the patient a bit about their memory, they give you a little bit of a response, and then they turn to the person sitting next to them. And it kind of gives the appearance of them sort of fading into the background during your encounter with them. And you're kind of just conversing with the other person that's come with them. The opposite happens with someone who's worried well, right? They talk a lot about their own memory themselves, and whoever's come with them, if someone has, kind of just sits there. It doesn't add too much. We consider the length of the history, as I mentioned. So with the worried well, the history is often quite short, so sometimes a matter of weeks or a few months, or alternatively, it can be quite long. So I probably had the problem for 7 years, 8 years, right? Generally speaking, as I mentioned, we don't see patients in the very early stages of developing dementia. So there's usually a history of about 6, 12, 18 months. Another important feature is the manner in which the symptoms are delivered. So in those patients who are anxious, stressed, or generally feeling unwell, you get quite a strident complaints. We saw that on the previous slide. So these patients talk a lot about their own memory. And when you ask them about the last time they noticed a memory failure, they'll be able to give you a pretty well contextualized complaint. So for example, they say, oh yes, it was last Friday, I was in my shed and I was looking for my hammer, right? So they're able to tell you a lot of detail about the memory that they forgot. In worried well patients, as I mentioned, the cognitive complaint can take in a lot of different systems. So I have trouble switching on the kettle when I make tea. I get my words mixed up in my sentence. I've forgotten how to spell. So often a lot of the symptoms have nothing to do with dementia itself. And then again, the other common thing you'll hear from this group is what we call attentional errors of capture. So the most common is walking into a room and forgetting why you were there. We all do this. If patients are complaining a lot about these sorts of features, so for example, had a patient say like she went to pour the milk in her cereal and just poured it into the pot plant, right? This absent-mindedness. Another example is like calling your kids by the wrong names accidentally, mixing up your words in a conversation. Those sorts of features tend to point to a predominantly kind of anxiety, depression underlying the cognitive difficulties. If you're not seeing that very obvious strident complaint, it may well be worth referring the patients for specialist neurological evaluation. In patients with early stage typical Alzheimer's dementia, as I mentioned, the complaint is rather muted. So there is a cautious concern that possibly their memory is not as good as it used to be. But this also tends to be accompanied by what we call a bit of a dismissive attitude. So as one gentleman said to me, you know, oh, my memory's not that bad, you should see the others at the bowls club. Or we had a patient recently who was an accountant, and he said he put his work-related difficulties down to just not really enjoying his work anymore and wanting retirement to come quickly, right? The other thing you'll notice is that these patients aren't able to provide well contextualized examples of their memory problems. So it's always helpful to ask, well, tell me the last time, you know, your memory failed you. Tell me as much as you can about the event. What happened? How did you recover from it? Patients with Alzheimer's dementia will really struggle. They might give a few vague examples around forgetting names, and then they'll tend to turn to whoever's with them. Are there any questions about that? So let's talk a little bit more about how patients with the atypical onset forms of Alzheimer's present in clinic. So as mentioned before, these forms are posterior cortical atrophy, logopenic aphasia, and the behavioural dysexecutive variant of Alzheimer's dementia. So in the atypical onset forms, there's an initial focal phase lasting at least 2 years with distinct symptomatology. So during this phase, patients don't present with the kind of muted, cautious complaint that I mentioned before. They often have very good insight into their cognitive changes, and memory is typically well preserved in that focal phase. So they first present to primary care settings, typically with complaints about language, about spatial functioning, or about kind of behavior, so planning, organisation, or concern from family about a change in personality. So I'll talk you through the brief kind of the key clinical clues for each of these conditions. So posterior cortical atrophy, as we know, presents with visuospatial dysfunction, not memory loss. So patients may describe things like having difficulty seeing objects or having difficulty recognizing objects. So I had one patient that said she would go to the supermarket and she'd stand in the butter aisle and she knows what butter she has in her house, but she just can't see it in front of her. And she literally closes her eyes, imagines it, opens them, and there it is. So she's sort of using this top-down facilitation. Other things patients might mention are difficulty judging distance, so going upstairs that they're not used to, parking the car in between the right spot, dressing apraxia. So I had a patient once who just couldn't work out how to put her mask on in the clinic. Patients might describe quite counterintuitive things, so having more trouble perceiving large objects than smaller objects. So any patient that comes to your clinic with concerns about not quite being able to see things clearly despite normal ophthalmology should raise concern for a PCA. The next condition, logopenic aphasia. So as mentioned, it presents with kind of slow, halting speech with pauses for word finding. Sentences are often quite simplified, the language is often quite sparse. And these features are often evident when you're talking to the patient, but you might have to push them a little bit. So with very familiar or routine conversations, language might seem quite normal, but once you start asking them about non-routine things, you may start to notice these features more. Patients will typically be quite aware of this problem themselves, and they'll complain about trouble finding the right words. So if a patient's coming to you saying that they're having trouble with word finding, it's been going on for a few months, again, probably worth referring. And then the last one is behavioural dysexecutive Alzheimer's dementia. So this can look a lot like behavioural variant FTD. The most common behavioural feature is apathy. So usually apathy is described by a family member, but you may also hear things, usually from family, that the person's just not quite the same person that they used to be. Their personality's changed, and they're not as warm. They're more disorganized in their life, having trouble managing, finances, work, and so on. And again, it's worth referring them for specialist follow-up so we can tease out what's going on there, and also the differences between, or whether it's likely to be reflection of an FTD versus an Alzheimer's. Any questions about that part? Right. So neuropsychologists play a critical role in the assessment, diagnosis, and management of young onset dementia, particularly where presentations are non-amnestic and diagnostically unclear. We also have a role in providing education to patients and close others about these conditions. And our findings can help guide management, inform the person's ability to work or drive, and help with accessing services such as the NDIS. In terms of what our assessments entail, we spend quite a bit of time taking a history. So in our service, we're afforded a lot more time to do this than is often possible in primary care settings. We then tend to do quite detailed assessment of memory, but other associated functions like language, spatial skills, attention, and so on. And we now have some very evidence-based neurocognitive markers of Alzheimer's and other neurodegenerative processes, and these can surface at quite an early stage. So there are a number of brief bedside tools which can be quite informative in helping us kind of detect dementia. And Dr. Fletcher mentioned some of these tools before. Screening tools like the MMSE certainly can play a role, but we find they're often quite insensitive at the very early stages of these conditions, particularly for the variants of dementia that more commonly affect younger people. So the non-amnestic forms of Alzheimer's as well as FTD. One more sensitive measure is known as the clock drawing test, and some of you might use this already. So essentially what we ask the patient to do is to draw a clock face, then the numbers, and then we ask them to set the time to 10 past 11. And what you might see in early stage amnestic Alzheimer's dementia is the patient puts one hand to the 10 and another hand to the 11. And there's a body of research now which has shown that this actually reflects a breakdown of the conceptual knowledge as for the numbers as representing both minutes and hours. But you may also see the clock is abnormal in other ways. So you can see here, there's an example from a patient with posterior cortical atrophy. So very prominent visuospatial dysfunction, right, in the way they've drawn the numbers, but also the hands are placed at the wrong orientations. There's also a clock from a patient with behavioural variant FTD. So you can see there's sort of perseveration both in drawing the numbers, they've gone past 12, but also in drawing the hands. So reflecting the patient becoming sort of stuck in a particular response set. And then this last clock was from a patient of mine with behavioural dysexecutive variant AD. So when asked to draw the clock, he's drawn this sort of wheel and spokes up the top. And then I've drawn a model clock for him down the bottom and gotten him to set the time, and he's produced that minute hand effect, which we typically see in amnestic Alzheimer's. All right. There are a few other brief measures which you might consider deploying in your clinic to kind of help identify who might benefit from further follow-up. So if the patient's presenting with concerns about memory, then measures of arbitrary associative learning are quite sensitive to dysfunction of the mesial temporal regions. So you can look at this using quite simple objects in your clinic room. So I typically use paperclip, maybe my water bottle, a pen and my glasses. What you do is you say to the patient, I've got 4 objects here and I'm going to hide them around the room. You're going to watch me do this. And then I'm going to ask you what I had and where I put everything. So you hide things in places that they don't typically belong. So I wouldn't put like my pen in my bag. I'd probably put it under their pillow or something like that. And then you ask them to tell you what you had and where they put it. And you can do up to about 4 trials of this. This is a very kind of easy test, right? And so if patients are struggling with this at about the 3rd trial, they're struggling to make that association, that is concerning and definitely worth referring on. Another measure here is the Cowart controlled oral word association test. And this is a freely available measure. Essentially, you're asking the patient to generate as many words as they can think of, beginning with the letter F, and then A, and then S, and you give them a minute for each. And then you ask them to generate as many animals as they can think of, and that can begin with any letter. And in people who don't have dementia, they will find the FAS task much harder than animals, because in our brain, we don't store words according to their letter, right? We store them by their phonemes. Whereas in patients with Alzheimer's, because you're seeing that breakdown of semantic knowledge, suddenly it becomes a lot harder to generate the animals than it does the other 3 letters. So it can give you a bit of a grab at whether there's something on the go there. And again, this is a very well-researched measure for detecting Alzheimer's. If the patient's complaining about word finding difficulties, then it might be helpful to just get them to name things around your clinic room. So again, your stethoscope, body parts, right? This is a wrist. You might have them name parts of clothing like a sleeve, and that should elicit a difficulty if there is one. And sentence repetition is really key. So even increasing the same sentence by small increments can often lead to like a breakdown in the ability to repeat the sentence. And that's because these patients can't actually speak back to themselves in their head. So it's an issue with the phonological loop. If there's suggestion of visuospatial difficulties, in addition to the measures Dr. Fletcher mentioned, you might also use what's called the Poppelreuter. You can see this here. So you're just showing the patient this and asking them what objects they can see that are overlapping. There's also a Taylor complex figure, which is again a freely available measure. And you just ask the patient, you show that to them and they have it in front of them and they just copy it in the space below. And if there's a visuoconstructional problem, it will almost certainly declare itself on this measure. And then finally, if there's a suggestion of kind of dysexecutive problems, Lurier's fist edge palm maneuver is a good one. The other good one that I like is go, no, go. So you basically tell the patient, when I clap once, you're going to clap once, and when I clap twice, you clap twice. You do that for a little bit, and then you change it up. So you say, when I clap once, you clap once. When I clap twice, you don't clap. And you give them a nice long run of the single claps, and then you give them a double clap and see if they can inhibit that response. I was going to plug our research briefly, but in the interest of time, I don't think I will. Just to say that Dr. Fletcher and I at the moment are kind of looking at kind of key clinical signs and features of patients' subjective cognitive complaints, which can predict the presence of an underlying degenerative process. So patients who are referred through Dr. Fletcher's clinic may well be eligible for this research, and that's something they'll be offered as well, just so it's sort of on your agenda as referrers too. So I guess the key takeaways are that, as we've heard, not all dementias start with memory loss, and visual, language or behavioural symptoms, particularly those in under 65, warrant further investigation. Early detection facilitates timely interventions, future planning, more efficient healthcare resource allocation, and consideration of disease-modifying therapies as they become available. And the TCH Cognitive Disorders Clinic welcomes referrals from GPs and other clinicians where a neurodegenerative condition is suspected. Great, thank you.